Dr. Lynn is the MS director at Ohio State University, or the Ohio State University. Dr. Lynn did not have the hundreds and hundreds of patients in the database that Chitra and Doug have amassed over the last 5 or 8 years. She didn't have that range of experience, but she took the risk, really, of extrapolating a lot of knowledge from the MS community to help us. And if you look at a lot of the material that we have published in the earlier newsletters and under the link about transverse myelitis on our website, a lot of it has been written by Dr. Lynn. So we will always feel indebted to her for doing that work. She's also on the TMA Medical Advisory Board, and maybe what is most important to Pauline and I personally, she's Pauline's doctor. And she's going to be talking this afternoon about a subject that is, I know, extremely important to many of you, and that is the treatment of neuropathic pain. Dr. Lynn?
Thank you very much, Sandy. Well, in the past, Sandy's asked me to talk about things I really don't know much about. He caused me to put up an article about sexual relations on the website for the TMA. So, in the spirit of disclosure, he's talked me into speaking about neuropathic pain. I am not a pain doctor. I'm not an anesthesiologist like Dr. Christo after me. I'm just a neurologist in the MS clinic trying to learn how to help. And it's very difficult because I would just say to you that neurologists in general don't receive a lot of training about how to manage pain. And so a lot of times we're learning in clinic. Okay, I got to figure out this crazy thing. Oops, I did the wrong thing. Got it. Okay. So we want to look at types of pain and clinical manifestations of neuropathic pain, and some of this will overlap with the next talk. Understand how pain neurons respond to injury and how different medications will modulate the pain pathways, and then talk briefly about various medications. So obviously I'm going to have to hurry. But there is a workshop on pain if you want to come and talk more later in the afternoon. Obviously, the most information is available for MS out of this family of neuroimmunologic diseases. And in most surveys of large MS populations, clinic populations, 45 to 55% of patients will say they have some sort of pain syndrome. This is obviously different than what they used to teach us, that pain wasn't really part of MS. There was one large survey they sent out to a group of over 1,600 patients to see what kind of pain syndromes they had in MS, and 2% reported back trigeminal neuralgia, which is a terrible, one of the worst pains, stabbing, lancinating pain in the face that's triggered by speaking or eating or chewing, to the point that sometimes I have to admit people to the hospital because they really can't eat and stay hydrated. I think you've heard about Lyrica, this electric feeling that spreads down the body when you bend your head. Various other types of abnormal dysesthetic pains, 18%, that's a fifth. Back pain, obviously, which may or may not be directly related to the MS. And then various painful tonic spasms. Sometimes people with spinal cord disorders get spasms of the hand or leg that are just a constant contraction, very painful. Pain in transverse myelitis, well, Dr. Kerr, speaking in the past off the website of his clinic experience, reports that 2/3 of patients with TM report severe pain at some time, either right at the midst of the acute illness or during convalescence, long term, and 40% of patients it continues as a major feature long term. All right, a little bit about pain. We talk about nociceptive pain. This is the kind of pain that happens when you burn yourself. Okay, you have activation of pain receptors because you're injuring tissue. muscle tear, pulled ligament, etc. There's also the pain when your bowels get blocked or something, or gallbladder's abscessed. But that's not really what I'm going to talk about. Then there's non-nociceptive pain, okay, and in particular we're interested in neuropathic pain, which is when the nervous system itself is injured, the peripheral nerves, the spinal cord, somewhere in there, and because of the injury it starts sending off abnormal signals that I'm experiencing pain, even though there's no tissue damage actively going on that we can see at least. We have a lot of words. I think Dr. Christo is going to go into that more if I looked at his slides, but you'll hear us talk about dysesthesias, which are spontaneous, unpleasant sensations without a clear cause. You're not being stabbed by a knife, it just feels like it. Hyperesthesias, sensitivities to non-painful stimulus, okay, just being touched feels painful. Allodynia, where pain produced by a non-noxious stimulus feels painful. And then hyperalgesia, when I'm doing my little neuroexam and touch with a pin, that might be briefly, very transiently uncomfortable, but for someone else it might have a spreading, prolonged, painful feeling. Okay. It's very important for us trying to treat pain to try our best to figure out what the cause is. So we like to ask questions, and if someone's having a pain, if they can come having thought about this themselves, that would be great. Location of pain, the characters, it's stabbing, burning, hot, cold, ripping, squeezing. What words would you use? Not just bad or it's all over. Because that's less helpful. Intensity, the temporal pattern, and what kind of things make it better or worse. These are some of the most common neuropathic pain syndromes, all right? And let me see if I can. Painful diabetic neuropathy and post-herpetic neuralgia. Okay, so people with diabetes get peripheral nerve disease, and they get all sorts of burning and pain. It hurts so bad they don't even want the sheets to touch their feet. All right, and that's very common because diabetes is so common. And then people that have herpes zoster, shingles, they also get pain syndromes that follow even acutely and follow the recovery of that. Those two are so common and so kind of standard that they are most often used as neuropathic pain syndrome models to study drugs in. So a lot of drugs that I'm going to talk about, this is where the studies come from, not something rare like trigeminal neuralgia, like TM, not something common but difficult like MS, where people have such a wide variety of characteristics of their pain. We also have cancer-associated pain, spinal cord injury, which could include TM, trigeminal neuralgia, post-stroke pain. People with strokes can have pain from injury to the spinal cord, and then HIV infections. It's good to talk about different kinds of neuropathic pain qualities, and sometimes the pain is described as burning, hot, steady, stabbing, deep aching pains. Often it's worst at night. Non-pharmacologic treatment of pain. Okay, I'm not going to go into great detail about this. We rely on physical therapists to help us, but modalities such as application of heat and cold, gradual graded exercise, because people tend to start to guard their painful limb or area of their body, acupuncture, sometimes transcutaneous nerve stimulation, sleep if you're fatigued, and we'll talk about fatigue. If you're fatigued, that worsens pain. It makes it harder to manage it, so we need to look into sleep quality. And then depression. Depression, you just heard a great talk about that, and it affects many things, your view of what you can do, and every pain syndrome is made worse by depression. Okay, also you can have cognitive therapies, such as sort of relaxation therapy, biofeedback, behavioral therapies. There's all kinds of non-pharmacologic approaches to pain. Again, treat depression, like Dr. Kaplan said. But now I'm going to try to go over some medications because I know it's probably baffling. We have this whole list of drugs that we pull out and start trying. It's like, I don't want to try more drugs anymore. And you probably feel frustrated, but I want to give an overview of the types and where we're coming from and why we're trying these. So first of all, when you try a drug in the best of all possible worlds, you'd like it if you understood the mechanisms of the underlying problem. It would be nice if I knew, oh, you have that stabbing pain. Oh, I know exactly where that is in the nervous system. I can locate that circuit. I know what neurotransmitters messed up, and so I know exactly what drug to use to fix that. But that's just not the way it is for almost all of our pain syndromes, because there's multiple things going on. We just haven't teased it down. So really we have very little information about the specific sites or mechanisms of dysfunction for various pain syndromes. We know that pain receptors, okay, wherever the nerve's injured or just a normal appreciation of pain, trigger electrical impulses in nerve fibers, and that information's taken back into the spinal cord, and that neuron releases glutamate as one neurotransmitter. All right, and then the glutamate activates second-order neurons. The glutamate's just a chemical neurotransmitter, and those neurons carry pain signals up to the thalamus and various other areas in the brainstem that modulate and control pain appreciation. What are some of the things that are going on? Well, in those nerve fibers that bring pain information in from the limbs and skin, etc., there are several different kinds of sodium channels that are needed for firing. And one kind's found only on pain-carrying sensory neurons. And if you have damage to that type of nerve, it can cause an increased number of sodium channels. And that affects the function of the nerve so that it becomes hyperexcitable, and it can start to fire on its own, say, something's stabbing you, shocking you, when nothing like that is happening. Or you can also just get recurrent nerve discharge. So it's set off once by something like being bumped, and then it keeps going off. So the whole system becomes sensitized, where it will fire off more easily, have a lower threshold to fire by this kind of injury. All right, we have some drugs that modulate these sodium channels. We'll come back to them briefly. Some of them are anti-seizure medicines like carbamazepine or Tegretol, lidocaine, tricyclic antidepressants. I'll come back to them. We also have calcium channels, and there are several of those. They're on the nerve fibers that come into the spinal cord and in some of the spinal cord neurons themselves. And if these channels are abnormal in their function or number, then you start to have this allodynia, where things that aren't normally painful become painful. And we now have drugs, Gabapentin or Neurontin, and Pregabalin or Lyrica, which bind to these subunits and inhibit them. All right? And there's more going on, of course. The nerve damage can produce excitatory neurotransmitters or chemicals that cause central sensitization, once you enter the spinal cord and the brain pathways for pain, and also cause damage to the descending pain control pathways that inhibit pain. So you have ones for norepinephrine. You've heard these drugs, these neurotransmitters, dopamine, serotonin, and we all have little opioids inside us. And if we injure and knock out those systems that control our pain appreciation pathways, then we're going to have more problems with pain. And then opioids decrease glutamate receptor activity. So all the meds we're going to briefly talk about, and I think I can keep on track, are affecting these things. We have three main classes we're using: antidepressants, anticonvulsants or anti-seizure drugs, and analgesics, which include opioids. Okay, antidepressants are a well-established older therapy. They've been around for decades. These are the antidepressants that were around before Prozac. Not so good necessarily for treating depression because of the high side effect profile, but good for treating pain because we can use lower doses. And they've been proven beneficial for some of these various types of pain. When we look at these drugs, at the various antidepressants, they're affecting these neurotransmitters, norepinephrine, dopamine, and serotonin in varying degrees, all right? and you'll see a little bit in my hand about that. The old ones, like tricyclic antidepressants, Elavil or Amitriptyline, Pamelor or Nortriptyline, are primarily a combination of serotonin and noradrenaline reuptake blockade. Okay, they have some other effects. And what happens is the nerve is sending information by chemical out to the next nerve. This is a pain signal. It's saying, you're having pain. And if this nerve can inhibit that transmission, that would be good in some pathways. So if you can block this neurotransmitter from being taken up after each firing, then it will stay around more. And this could be one of those pathways that inhibits the perception of pain. Okay, so if we're going to treat with nortriptyline, amitriptyline, the guidelines are to start low and increase slowly. All right, and you have to make accommodations for age. We start if someone's younger than 65. That's just an estimate. Maybe start with 25. Also depends on weight and size. Greater than 65, start lower, go up gradually. But you have to look out for glaucoma problems, urinary obstruction, asthma. You can't use those drugs in those situations. And typically, the old tried and true is to keep increasing the drug until pain relief is achieved or the person's kind of knocked out with a side effect. So we don't always try to go for that anymore, but that was sort of the simple thought. These are some of the side effects from tricyclic antidepressants: dry mouth, constipation, not so good if you're non-ambulatory, weight gain, urinary retention, tachycardia, drowsiness. All right. What about the new drugs? Paxil, Prozac. These drugs are not so good for pain, for neuropathic pain. They've been studied in the diabetic neuropathy condition, and they're less effective than some other agents, but great for depression. What about some other newer antidepressants? Serotonin, norepinephrine reuptake inhibitors. Venlafaxine or Effexor inhibits norepinephrine and 5-HT and has been effective in pain, but it's not one that's being used as a first line. And here's Cymbalta, okay, which has been improved for painful diabetic neuropathy, relatively few side effects, and could also treat depression at the same time. So it might be a 2-for-1 drug. Then we have a group of drugs that are mainly norepinephrine and dopamine. These are neurotransmitter systems, and bupropion or Wellbutrin has been helpful in some. So we have a lot of choices. Okay, this one can cause weight loss or insomnia. We have to look at what kind of problems the person has and try to match them up to their tendency towards sleepiness or insomnia or whatever. For all antidepressants, we should consider the FDA black box warning for increased risk of suicidality in depressed patients treated with antidepressants that's been recently put out, especially adolescent and pediatric patients. But all this means is that we should continue to do what we've always done, which is to assess for comorbid depression and suicidality, and what Dr. Kaplan told us about. Okay, another group of drugs, anti-epileptic drugs. Gabapentin or Neurontin is FDA approved for post-herpetic neuralgia or zoster in the U.S., neuropathic pain in general in the United Kingdom. It blocks these sodium channels. It may decrease the process of sensitization, which with lowered thresholds for pain, and it's a great side effect profile for most people. I just talked to somebody out in the hall who said they couldn't handle 1,800. Some people can't handle 900 a day, but some people can walk this up to 5,000 a day. People have a great variation in what they can handle. Pregabalin or Lyrica, okay, this is the calcium channel blocker that's just come out recently. I'm just getting used to using it. All of these can cause sedation and ataxia as you push up, but it'll be interesting how that works for some of the pain syndromes like you see in transverse myelitis. Tegretol's an oldie, which is especially good for trigeminal neuralgia, the facial pain seen in MS, but it can cause sedation and balance problems, etc. And then there's some other antidepressants that are, anti-seizure medicines that are down the line, but in part they just haven't been studied, in part they may not be as good, but they're things you may see people trying. Topical agents, lidocaine patch, capsaicin is this cream from the chili pepper that affects pain fibers, burns when you initially put it on, but then may cause some degeneration of nerve fibers that will help in the long run. And then some pharmacists are willing to whip up various other topical agents. Miscellaneous agents, baclofen, we're more used to hearing about that for spasticity, but it may help with pain, and clonidine. I'll skip that. Opioids. All right, well, basically, most of us who are not anesthesiologists or pain docs are typically a little scared of these, or maybe a lot scared, and neurologists tend to be conservative. And then there's some studies in the past that have said it's less effective for neuropathic pain compared to tissue injury pain. But it's certainly appropriate for a person with moderate to severe pain who's failed other types of treatment and is willing to accept sort of a structured prescription program. May be associated with tolerance, so you may need higher doses over time. May be associated with physical dependence, okay, with withdrawal symptoms when you stop. But most people with a pain syndrome do not develop addiction or drug-seeking behavior to satisfy drug craving when you're trying to legitimately treat a pain syndrome. You can set up an opioid prescription program to try to especially try to reduce the risk of addiction and abuse and diversion, and that's scheduled appointments and agreements to obtain all analgesics, opioids through one doctor, and maybe even making a little contract of agreement on the rules between doctor and patient. We have tramadol, which is a weak opioid receptor agonist or stimulator, and also has multiple other effects, morphine, Vicodin, oxycodone. So I'm not pushing this, and I'm pretty conservative in my use, but I think we all have to use them when the pain's severe enough that other things won't help. Combination therapy of pain. I'm almost done, Sandy. Patients consider a 30% improvement in pain to be significant. There's been a little questionnaire. What would you consider to be worth it? And that's what came out. In many treatment trials, only 1 out of 3 to 4 people treated will experience moderate improvement. So that tells me you got to keep trying stuff. And also because of the uncertainties that we have regarding the underlying pain mechanisms, you have to keep trying things. Common approach is to start with one and titrate it up, like I said, until you're knocked out. But there's been some recent studies that show that a combination of gabapentin and morphine might provide better analgesia than each separately at lower doses for each. So I think we'll see more studies maybe of combinations too. And I'll stop with that.